evening, everyone. I shall be talking on the subject of lasers and light-based treatments for refractory melasma in the Asian patients. I understand that you all know what melasma is, but I would like to say that it's one of those disorders that causes severe psychosocial stress and adversely affects the health-related patient's quality of life. As already has been talked before, that melasma is classified into epidermal, dermal, and mixed melasma based on the Woods lamp examination, and it is the epidermal melasma that responds better to the most treatments available for this disorder. However, practically it is seen that even some of the patients with epidermal melasma do have a refractory melasma, and this is perhaps because of the poor correlation that exists between the Woods lab classification of melasma as compared to the evaluation of the skin biopsies for melasma. And some patients with epidermal melasma have hyperactive melanocytes, and they do not respond to most topical treatments, and that's why we have to resort to some of the other modalities of treatments available. So this slide shows different type of treatment modalities that are available, and there is no doubt that still today the Kligman's formula is considered as the gold standard for the treatment. But there is a very significant number of patients who do not actually respond to most topical treatments, and you have to depend upon the physical modalities of treatment. So what I will focus on is laser and light-based treatments available for treating refractory melasma in Asian patients. This slide shows the different type of lasers that are used for treating melasma, and as Dr. Tay has already given us a detailed account of most of these laser treatments, so I will just mention briefly the evidence-based treatment outcomes in these laser treatments, and then I will describe study which we have conducted in our setup using next generation of IPL. I would say it's a fluorescent pulsed light. So among the pigment specific lasers, Q-switch and the YAG laser is the one that was I think the most early used in the treatment of melasma, and initially the high energy laser treatments resulted in most of the untoward effects that we often see in the literature. And laser toning, that is low energy Q-switched and the YAG laser with frequent passes, has a very good appreciable results documented in literature, and that has been shown on confocal microscopy and as well as ultrastructure studies. However, untoward effects are there, and still this cannot be said as a definitive treatment for the refractory melasma. This is the confetti-like hypomelanosis that was seen in one of our patients with laser toning. Then fractional photothermolysis, this is one of those modalities which has shown very promising results in the treatment of melasma, and it is one of those treatments which is also approved by the FDA for treating this disorder. Certainly it has good effects, but the effects are really limited to phototypes, skin phototypes 1 and 2. Because as we go down the darker shades of skin, the efficacy goes down. In its very early pilot study that was done in 2005, 10 patients were treated, 6 responded very well, 70 to 100% regression in melasma, and those who did not respond well were actually Hispanics with skin phototypes 4 or 5. Similarly, other studies have shown that in the treatment of melasma in Asian patients, the critical evaluation should be done before embarking on the treatment because of the untoward effects that are seen, and they are like prolonged erythema, edema, pain. Although they are transient, but they are more common in skin types 3 to 5. And the recurrence was well resisted in most of the patients with Asian skin. Then this is a new wavelength that has been used, 1927 fraction thulium fiber laser, and there are two studies done in China and in Taiwan, and they have shown good results, but these studies are on a limited small patient sample, so larger studies are still required to see the long-term effects of these lasers. Then Q-switch laser, conventionally the classical Q-switch Ruby laser was discussed controversially, many problems like hyper and hypopigmentation, but there is a recently developed new 694 fractional Q-switch Ruby laser, which is considered safe and effective option for treating melasma in Caucasian patients. So post-inflammatory hyperpigmentation or recurrence of melasma at follow-up are again the possibilities. So there are limited data of its use in the Asian or pigmented skin. Then ablative lasers like erbium YAG and carbon dioxide lasers, they do give a very prompt result, regression in melasma, but this is then followed by a rebound hyperpigmentation and recurrence of melasma, and in broader terms they are not considered safe for pigmented skin. Lot has been already talked about the IPL in melasma, and favorable outcomes have been reported in patients with refractory melasma treated with IPL, like the two studies mentioned here. One was on the Chinese patient, another one was on the Taiwanese patients. But again, the darkening, sloughing of skin at treated sites, microcrust formation, post-inflammatory hypopigmentation and hyperpigmentation are some of the adverse effects, and the overall conclusive view about the IPL is that it does give modest improvement in patients with refractory melasma alone or in combination with the topical therapy, and it is appropriate for patients who do not mind 1 or 2 weeks recovery time or a downtime. So then people to have better outcomes, people have used combination of lasers like combination of this low fluence Q switch with fractional photothermolysis and impulse pulsed light with Q switch Ruby laser, and the ultra pulse CO2 with Q switch Alexandrite laser. And most of these studies, they document better results with combinations as compared to the single therapy. So combination of lasers and light-based treatment with topical bleaching agents is another very important area where you see better results when you apply these bleaching agents before and after the laser treatments. So I'll just quickly go through one of the study which we have done in our department. We used combination of topical 5% magnesium ascorbyl phosphate and fluorescent pulsed light for treating cases of refractory melasma. We selected ascorbic acid because of its efficacy in inhibiting tyronase activity and consequently suppressing the melanogenesis. It also has an antioxidant activity, reducing the production of free radicals which trigger melanogenesis. But since ascorbic acid is unstable, so we used magnesium ascorbyl phosphate topical cream, which was used in strength of 5% for use before, during and after the laser treatments, light-based treatments. So this is the advanced fluorescent technology device which we used in our treatments, and This fluorescent pulsed light is actually non-coherent light like intense pulsed light with little differences in its configuration. It's a square-shaped pulse with lower peak power and widened pulse duration. uh, what does this technology, how does this technology is useful in patients is that most of the shorter wavelengths lights are cut off. They are prevented from hitting the skin, uh, which is actually injurious for the skin treatments, as most of these shorter wavelengths are absorbed by the epidermal melanin. Then these light waves are passed through another filter which converts them into a longer wavelength, therapeutic wavelengths, and therefore it increases the overall spectral emission. This is the shape of the wave. It has a lower peak power as compared to the conventional IPLs, and it is a longer pulse duration, and it has an equally distributed fluence. So better efficacy is anticipated. So we enrolled patients with skin types 3 to 5 with refractory melasma. They were both the epidermal and mixed type of melasma patients. They were treated for 12 weeks with topical application of 5% magnesium ascorbyl phase phosphate at night, and 3 sessions were offered of fluorescent pulsed light at 3rd week, 6th week, and 9th week. So they had used this MAP 3 weeks prior to their first FPL session, and they continued another 3 weeks after their 3rd FPL session. Then after 12 weeks of treatment, they were followed up for another 12 weeks to assess the persistence of treatment benefit, during which period they continued using the sunblock, which was actually used throughout the period of treatment and observation. This was the module setting which was used. We treated them first session with 12 joules per centimeter square and increased it by 1 joule in the next 2 subsequent sessions if they had tolerated the earlier fluence. So evaluation was done objectively and subjectively. The objective assessment was done using the mean MASI scores, and the subjective assessment was done by comparison of the pre-treatment and post-treatment photographs by an independent observer, and self-assessment by the patient themselves, and this was on a 4-point scale: poor, fair, good, and excellent. We also recorded any possible untoward effects of these treatments. So we actually treated 65 patients who completed the study. There were 47 females and 18 males. Ages range from 18 to 43 years, and duration of melasma from 12 months to 60 months, up to almost 5 years. And there were 13 patients with epidermal melasma and 52 patients with mixed melasma. So baseline score, mean MASI score was 14.8, which reduced to 10.12 by 6th week and further regressed to 4.53 by the end of the treatment phase. They were followed up for another 12 months, and by 24th week the MASI score has again increased to 6.35. This is the graphical representation of changes in mean MASI score. The percentage reduction in MASI was at 12 weeks 69.3%, and 24th week it was 57%, and which was statistically significant at both the endpoints. Subjective assessment as done by the independent observer: poor 7, fair 24, good 23, and 11 excellent. Among the patients, poor 10, 26 fair, 21 good, and 8 excellent. If you look at it, that score 3 and 4, that is good to excellent, this was registered by 44.6% of the patients themselves, and in 52.3% of the patients by independent observer. This percentage is low because of the higher expectation of the patients themselves seeking treatment. There was no significant side effect. Only 5 patients had erythema, which subsided within 24 hours, and the 4th patient had some peeling of skin, which did not require any specific treatment. So I'll just go through some of the patients who underwent this treatment protocol. You see the improvement which we have seen in our patients. This is actually a soldier who has a lot of sun exposure, but obviously with sunscreen, lasers and ascorbic acid, there was a very significant reduction. This area, upper lip area, is a very difficult area to treat actually, you know, as you can see the difference. Similarly in this patient. Melasma in males is equally common in Asian patients. This treatment also had some global effect on the skin texture. There was improvement in the acne scars also, and the post-inflammatory pigmentation that was caused by acne. Similarly in this patient also. You can see, appreciate the brightening effect, overall brightening effect of the skin. So we could bring these smiles back in our patients with this treatment protocol, and this, I would say that combination of 5% magnesium ascorbyl phosphate with fluorescent pulsed light is effective and safe in treating melasma in Asian patients, but it is definitely a need to have more treatment sessions and some kind of a maintenance for maintaining the treatment benefit or improvement. So this is my last slide. I would say that lasers and light-based treatments for melasma are useful therapeutic options for cases of refractory melasma only. There's not a first-line treatment, and pre and post-operative use of topical bleaching agents make these procedures safe and more effective. And finally, the time-limited clinical improvement and need for maintenance treatments is always there. Thank you all. If there are any questions, I would like to answer them.
Thank you, Dr. Zafar, for the excellent talk. Any questions for Dr. Zafar? In your analysis, were they analyzed by blinded photographs, or how were the patients analyzed in the study?
It was a blinded, it was an independent observer who had not seen the patients. We gave him before and after photos of the patients, and we told him to grade them according to scale 1, 2, 3 and 4.
Okay, thank you very much.